Good evening. I'm Dr. Abaza. I'll wait 1 minute and then we'll start to be sure to have enough time to discuss. Okay, so let's start this Facebook Live, which I will acknowledge it's the first time ever for me. So I hope this will go well. My name is Rémi Rabaza-Loret. I am an adult endocrinologist in Montreal, Quebec, and I'm what we call clinical scientist. So I'm both seeing patients and directing a research program, which is mostly focused around hypoglycemia prevention. So the idea tonight is to try to give the information to the people living with type 1 and their relatives some kind of information around the impact, the risk of what this COVID-19 outbreaks could mean for the entire community, specifically from the patient point of view. As I'm following personally approximately 400 patients living with type 1, I had a lot of feedback already on how this is stressful. So there is already a lot of information online around the disease, but still there is not so much around specific things related to type 1 diabetes. And as always, people living with type 1 are always diluted in the big words diabetes, and you all know about the fact that it's far more around type 2 diabetes than type 1 diabetes. So the first thing we started was to try to really see what were the questions we had the most frequently, and I did this with jdrf and with a few colleagues like Bruce Perkins in Toronto, like Farid Mahmoud in Toronto, also Peter Senior in Edmonton, and I think also Dina from Vancouver had some contributions. So I will start first to try to summarize some very frequently asked questions. So one first question we have very frequently is, if I'm living with type 1 diabetes, do I have a higher risk to get infected than someone not living with type 1 diabetes? So at this point, there is no evidence that with type 1 diabetes, there is a real high risk. This say there is a lot of things that we don't know. Overall, people with diabetes, not separating between type 1 and type 2 in the first reports from China, seems to be at higher risk. But there is nothing in those reports about specifically for type 1. A lot of things seems to be related to age. As you know, people living with type 2 are generally older than people living with type 1, but we know that some people living with type 1 are above age 60, 70, where there is clearly a higher risk. We have no clues about the fact that maybe type 1 diabetes is actually related to A1C, yes or no. So we are looking here to see if there is any kind of things around this. So in general, there does not seem to be a specific risk related to type 1 diabetes, but there might be some risk of some people living with type 1, maybe if you're on very bad glucose control, maybe if you are older, maybe if you have complications. I have already one question about, is there a specific risk if I'm living with type 1 and working in healthcare systems? It might be. It is clearly extremely unclear for this. And again, if there is a risk at this point, things are changing so rapidly, it seems to be really related to maybe the degree of control, definitely the age, and definitely the presence of maybe some complications. For example, people living with heart disease and kidney disease obviously seems to be more at risk. I apologize. It seems that some of you were not able to see me. I hope this is again. So I will go very short of what was already said First point, I'm Rémi Abaza from Montreal. I'm an adult endocrinologist, but also researcher in diabetes. And the first question we were going to try to answer is, are people living with type 1 diabetes at higher risk of being infected by COVID-19? The answer is, at this point, there is no evidence besides some risk factors that are already known, like age, above 60, 70, depending on some studies, about the fact that people living with some significant complication like heart and kidney disease might be at high risk. And beside that, outside of COVID-19 infection, in general, people that would be under very bad control probably have a higher risk around being with diabetes. Now this will link to the second most frequent question we are getting. It's, if ever I get infected, is there a worse prognosis? So what we know in general around viral infection is that consequences might be more significant for people living with type 1. Specifically, again, if they have heart disease and or if they have kidney disease, and also maybe again with the age factor above 60, about 70. We know that what's for sure is that getting an infection and living with type 1 diabetes add an additional layer of complication around getting blood glucose under control. An infection is driving blood glucose high. In general, sometimes you try to correct and you would get low. So it's a clear factor driving glucose up, but it doesn't prevent from lows. And high blood glucose can lead to dehydration, which is not very good with blood glucose because it can bring blood glucose higher. What we know from Chinese data is that obviously a lot of the people that were reported as diabetic in the Chinese data seems to be living with type 2. I only was able to get one case where it was very clearly stated it was someone living with type 1. So all those factors are very, very hard to do. Again, the age factor is evident. Living with significant complication like heart and kidney disease is quite evident. But a lot of data reporting that diabetes is increasing the risk is probably more related to the age and other conditions rather than the fact of being living with type 1. We are going to try to see this more clear, but at this point, we have very, very scarce data about specifically type 1. The third most frequent question we received is, should I get some specific extra precaution? And I saw before we had that short interruption that it might have been possible that people are saying, for example, if I'm working in a healthcare environment. So we know that social distancing, all those washing hands and things that we've been hearing repeatedly, staying home as much as possible is obvious measures. As a general advice, I would really advise people living with type 1 to get in touch with their healthcare teams and to try to do as much as possible any follow-up currently online by phone. Here at the large clinic we've made that turn within 48 hours, and frankly, it goes relatively well as far as, trying to prevent really high, trying to prevent really low, reassure people. I'm unsure we're making a perfect job in a fine-tuning, but we are getting everything around. It might also be if you're living with type 1 and really struggling with your blood glucose, let's say a quite recent high A1C or recent blood glucose from continuous glucose monitoring that are really high, we know in general that this might increase the consequences of an infection, so it might be a good time to try to bring it down. Does this specifically apply to COVID-19? We have strictly nothing to do. So I would advise people to follow all the general rules, to postpone any clinical visit. Also, probably to postpone a lot of routine labs. We can work now with CGM and pump downloading, but CGM is already bringing a lot of information we can work. The fourth most frequent question was coming from parents of kids living with type 1 around, is there any specific risk? So here, there is two layers in the answer. The first thing is that any report, including some early report from China and Europe about kids living with type 1 having COVID, but beside this, the disease seems extremely mild in kids. At this point, there is no major report of very bad outcomes with kids. The second thing is that just like for adults, and maybe even more, the risk of having very high blood glucose that could lead to diabetes ketoacidosis and those kind of things needs to be monitored very closely in everyone, but even more specifically in kids living with type 1. So monitor blood glucose, have ketone strips. If you don't have them, it's time to call your healthcare team so they can fax a prescription to your pharmacy. Be prepared to have a bit of extra insulin. Be prepared to give fluids if the blood glucose are a bit high, and be prepared of a low blood glucose if you have been a bit too much aggressive. They will be on the jdrf webpage, and most clinics do have pages where you can log on and have some guidance for sick days if ever it happened. The fifth most frequent question, and then I'll have a 6 and 7, and then we'll open for discussions, is there any risk for supply issues both with insulin and with material CGM, continuous glucose monitoring is really upfront. So I've been in the last 2 days in contact with any big companies of insulin, of material, CGM, insulin pumps. And at this point, all companies have very good storage. They have material there. We anticipate no disruption in the chain. Locally, you can go to your pharmacy and one day they might don't have the 10 milliliter vial of whatever rapid insulin you're putting in your pump. At this point, the retailers are not authorizing pharmacy to make stores. So it's a bit like the toilet paper issue. It might not be there today. It should be there tomorrow. So the general advice is no issues with supplies at this point, either insulin or material. You might have a little of more extra insulin. Don't go to the pharmacy the very last day you need it. But at this point, we need really to reassure everyone, all the companies were really clear on the fact that there is no insulin shortage, there is no material shortage. Then we had the next questions were around other medication than insulins. There is two classes of medication where we had a lot of questions. The first one is around some low blood pressure medication that are also used to protect kidneys in a lot of people living with type 1. Their names, their complete names is ACE and ARBs, angiotensin converting enzymes inhibitors and blockers of receptor of angiotensins. All those medication usually finish by pril or stan, depending on the two class you have. There is absolutely no good evidence that those medication would increase the risk. On the opposite of what is written someplace, some web pages, they are very good evidence that stopping them could actually be harmful for people. So all big scientific societies, Canadian Cardiovascular Society, and actually some big diabetes societies also have taken the position that at this point patients should not stop them. This said, those medications might be in some circumstances hard to manage during sick days. So if unfortunately you become sick, don't stop them, but it's a good thing to mention to your healthcare teams after you have all the contact to try to manage things at home as much as possible. And there's good evidence that that a lot of high blood sugars can be managed at home. To say, by the way, you also have those medications to protect my kidney, to lower my blood pressure. How should I manage them currently? The second type of medication that we do had quite a lot of question is medication like ibuprofen, Advil, Motrin, all those other brand names that we have a lot of this. So some countries like UK and France said don't use them. Some others like Canada say don't use them first line. We have acetaminophen and that's enough. Those anti-inflammatory medication can be used for other conditions, let's say arthritis, for example. And if you're using this for that condition, you should not stop them. If you still use them because they are very efficient against pain and against fever, be careful if you have advanced kidney disease. The final thing is that with acetaminophen, so the first line medication that is advised, some continuous glucose sensor can give false data. Not all, but Dexcom G4, G5, and light sensor are not, there can be an interference there, so you need to go far more to finger sticks. Okay, so I'm now going to try to take the questions from the beginning. So let's see this. First questions. Any indication to take extra vitamin D? So vitamin D is supposed to protect from a lot of things from the internet. The evidence beside bone disease in reality is not there. Can vitamin D could help for infection? No good data from the literature. Probably no harm to take it a bit more, but there is no obvious data for vitamin D. A lot of confusions between type 1 being at risk, yes or no, to have more COVID-19. As I said at the beginning, no good evidence might apply to people under very bad glucose control. More evidence for people at older age and with consequences. If you get sick, then there could be a lot of additional layers, including the hard things in terms of managing blood glucose at that time, for example, with the risk, an increased risk of diabetes, ketoacidosis. So what is the blood glucose range to stay safe? The usual blood glucose in most patients safe is between 4 and 10. It could be acceptable at some point to raise a bit the lower value at that time if you're really worried about hypoglycemia. But the general message is be prepared. Be prepared to be able to manage an unexpectedly high blood glucose. Do you know what to do for sick days? Do you have insulin? Do you have ketone strips? Do you have a bit of blood glucose strips if ever your continuous glucose monitoring run down? Do you have glucagon to treat low blood glucose? And some of you might know it's not covered everywhere. There's a new, nice, easy way to have nasal glucagon to be there. So get prepared. That would be my main things. I am now looking to this. So back order about things are up to June. This is obviously not true. And if this would persist, and if you test another pharmacy, I would urge you to go directly to the direct company. So let's say you have an insulin, a pharmacy telling you that there is an insulin shortage. That is not true. I've been checking this all the 2 last days. But let's say you are with a specific brand. You just call the customer line of that brand and say, my pharmacy is not having it. And actually, this should solve the problem for this. So let me look. Yeah, there's a lot of people thanking me. That's nice. It's better than when I discuss with my kids, and I'm thankful for this. It's good for my self-esteem. Mortality rate with diabetes. Obviously, this is the most worrisome. So to summarize again what I said, there is some good evidence that mortality rate has been raised in the Chinese data. This said, they did not separate between type 1 and type 2 diabetes. They did not give an indication if this was more applying to people, let's say, with very bad glucose control or higher age or already some complication. And we do believe that a large part of this is related to the age factor, to the presence of other disease like heart disease, kidney disease, and maybe to bad glucose control. Something else. Did I say that we should avoid ibuprofen? I'm not saying this. I'm saying that some countries have said do not use it. The obvious evidence that it could increase the risk is not there. It actually all came from the French health minister in a Facebook Live, so I hope I won't do exactly the same thing here. We are telling use acetaminophen, Tylenol first line. Be careful with some continuous glucose monitoring. It might change the validity of those things. If you want to use ibuprofen, if possible, please go to your healthcare team to discuss your own risk because, for example, with kidney disease, it might be a problem. If you are already using ibuprofen for other conditions like arthritis, you might keep it. Some others are telling that ibuprofen should be avoided with CGM. It is more acetaminophen. The interference of ibuprofen with CGM is not there. So Tylenol, ibuprofen can interfere with some CGM. The one I know to do so are Dexcom G4, Dexcom G5, and some version of the Medtronic and Lite. Newer generation seems to be safer. Some we don't know exactly. So just be careful if you use this. And other actually are giving the same advice as I did, which is always reassuring. What do you consider as a reasonable A1C? This is really to be personalized. So my first advice is routine lab test. It's not the time to do so unless your healthcare team is really telling you we need to do this. A lot of people living with type 1 are using CGM, and we can estimate blood glucose control and A1C from this. Now, A1C, the target is usually 7% for most adults, but it can be higher. For example, if you had a recent severe hypoglycemia, if you don't feel those hypoglycemic events with no symptoms, it can be completely different in pediatric milieu. So it's very hard to answer to that question. Usually it is around 7%. It can be higher for quite a large fraction of people, like some pediatric patients. So now there's people interacting with each other. Do we know things around Libre and Tylenol? That's Freestyle Libre is a widely used intermittent glucose monitoring system. That's something that is not extremely clear at that point. I would advise to be a bit more cautious and to check with blood glucose, and reminding everyone capillary blood glucose will never be the same as the one under your skin. There is always a delay. Blood glucose, capillary blood glucose moves more rapidly than the one under the skin, and the more rapid fluctuation you are undergoing at the time you test on your finger, the more the lag time can be. So it's not always the same, but just check that you're not too far or further than what you already observed in the past. What about workers and people living with type 1? So I'm going to give two layers of things here. If you ask a lawyer, she will tell you we cannot recommend of getting out of work at this point. So there is no legal advice at this point. What I can tell you I am doing as a physician, and I know some of my colleagues are not doing it, I am really trying to push very hard with some certificates so employers are moving people of remote work for all people living with type 1 to reduce as much as possible. Once again, not because they are high at risk, there is no evidence for this, but if ever they would get infected, we believe at least the blood glucose management would be harder. So I am personally more keen to make certificates, not of getting out of work, but pushing on the employers to try to protect a bit more someone living with type 1 than someone else that would not be living in type 1. Any advice about vitamins to boost immune system? Actually, there is no good data around this. So there might be no harm unless you give a lot of vitamins to kids, but vitamins boosting the healthcare system is more for some shops to sell you than other things. Doesn't mean vitamins are not important, but probably no harm, no evidence of boosting the immune system. A bit the opposite. Do some patients with type 1 have a weak immune system? No. Actually, you probably even have a too strong immune system. It went wrong one time and it broke your pancreas. There is no evidence for weakened immune system. Now you can live with type 1 and have other conditions that would increase this. For example, if someone is tonight online and is living with type 1 and have a kidney graft and have an anti-rejection medication, this obviously increases this. We are close to the end, so I will try to see if there is no question that overlap around what I said, and I am not seeing this at this point, but I would remind the key messages from tonight. Probably no specific increase related to type 1 diabetes to get infected. If getting infected, managing blood glucose is quite hard already. Be prepared for sick days. And I think I am there. I really appreciate for you taking time to come. And please say to GDRF if we need to do more and do it again. It evolves very, very rapidly. I really, really appreciate that GDRF could allow us to do this. There is a specific GDRF webpage, and we are coming very shortly with a Q&A things that I did with a few colleagues around the country. It will be available both in French and English very shortly. So thank you very much for joining, and have a good evening. Bye-bye.